Hello, I'm Dr. Rebecca Bernard, and this is Patients at Risk, a discussion of the dangers that patients face when physicians are replaced by non-physician practitioners. I'm joined today by my co-host and the co-author of our book, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, Dr. Maron Al-Ajba.
Hey, good evening.
Dr. Stephen Maron is a pediatrician with 32 years of experience. In 2018, he was fired from his job at a federally qualified health center, treating underserved children because of an editorial that he wrote to his local newspaper, simply explaining the differences in training between a nurse practitioner and a physician. Steve, thank you so much for joining us.
No, thank you very much for having me. Very pleased to be here.
Steve, I have to tell you that your story was one of the reasons that I decided to write a book about this transformation in healthcare. When I learned that children in desperate need of healthcare were being deprived of an experienced pediatrician simply because of a political agenda, I knew that this story had to be told. Can you fill our audience in on the backstory?
Absolutely. I'm a graduate of Tel Aviv University Medical School. After that, I trained in pediatrics in the U.S. And I've done a number of different gigs throughout my career. I have had my own private practice. I've been in a number of employee physician positions. And I've, throughout my career, worked with nurse practitioners, never had a problem, very positive interactions with them, going both ways. At times, I would consult the nurse practitioners on certain matters where they had more expertise than me, and they would consult me, take a look at this rash on this kid, or what should I do in this particular situation. My most recent position, the position which led to my firing, was at a federally qualified community health center, United Community Health Center in Green Valley, Arizona. And there I worked with nurse practitioners really without a hitch. I also precepted nurse practitioners. My first inkling of a possible problem was when I asked to see patients who the nurse practitioners had seen in follow-up, those who had slightly more complicated problems. And I would tell the particular nurse practitioner, you know what, let me see this patient in follow-up because I really have to go through the chart, do a little careful review the medical topic, perhaps. And the parents are probably going to be okay with it. Just make sure they are okay with it. I got a visit following that from the CEO of the organization who told me, listen, this practice of yours is ruffling some feathers. It's disrespectful, which really surprised me. Why disrespectful? Where's the disrespect? It appears that you're doubting their ability to treat these patients. I explained I just want to do things conscientiously and properly. And that's the way I've always practiced medicine. And that was just the beginning. After that, I started noticing that patients that I had collaborated upon with hospitalists in the hospital to manage were being followed up by one of the nurse practitioners. They were often quite complicated, but this particular nurse practitioner was very intelligent. She was very well thought of, and she had a very loyal following. So even though I had been involved and had been speaking to the parents while the child was in the hospital, they really wanted to follow up with their nurse practitioner. So I would present to this nurse practitioner and tell her what was going on and give her really a formal presentation. But I was a little concerned because a lot of these cases were actually pretty complicated, and I thought she didn't quite have the background to manage them properly.
Right.
Meantime, they were stacking my schedule with well visits, well babies. I love to do well baby visits, but that's not really good utilization of your available resources. You have the pediatrician doing well visits, and you've got the nurse practitioner seeing all the complex medical cases. Wrote an email to the management, and the response to this was inviting me, quote unquote, to a lunch and speaking to me quite clearly about how we all have to get along here. And now following this was the whole issue with the article that appeared in the local paper. And
Steve, if you don't mind, I'd like to fill the audience in a little bit, give them a little bit of background. On
Sure.
January 3rd, 2018, your local newspaper, the Saharita Sun, if I'm saying that right, published an article, and it was called "The Doctor's Not In, These Two Will Be." And it was an article featuring two area residents who were nurses pursuing a doctorate degree at the local nursing school. So just to read a few clips from the article, quote, "Going to see your family doctor for basic needs may soon be a thing of the past. Joan Shaver, a professor and dean at the University of Arizona's College of Nursing, predicts most people will eventually rely on nurse practitioners for their primary care needs. They'll assess for disease, treat common ailments, and help people manage their stable chronic conditions. Nurse practitioners are registered nurses with a doctorate of nursing practice. They are licensed to evaluate and diagnose patients, order tests, and prescribe medications. In Arizona and 22 other states, they can work without having to consult with a doctor." The article interviewed two NP students, and one of them was a person by the name of John Sparks. At the time of the interview, he had been a nurse for 3 years, but he was scheduled to graduate with 2 doctorate degrees in nursing the very next year. And in the article, he said, nurses tend to focus on the whole person, not just the disease. NPs spend more time with patients and are trained to listen to the wishes and desires of the patients. And the article also reported that he said that most Arizonans are already used to the idea of nurse practitioners, and he didn't think that people will complain if they take the place of primary care doctors. And after all, he and his family had been seeing nurse practitioners themselves for years. Steve, tell us what your thoughts were when you saw this article in your local newspaper.
My immediate response was, this is not quite right. This is not correct. And I wrote a very carefully worded response to the online version of this article that had appeared. The editor of the newspaper saw my response. He knew me because I had written medical columns for the newspaper. And he said, "Hey, Steve, why don't you write an op-ed on this?"
And it was a beautiful op-ed, and I'd like to read.
Well done.
Yeah, I'd like to read a little bit from it. It was actually quite complimentary to nurse practitioners. He began the article by saying, quote, "I am a practicing pediatrician in the community. In the course of my job, I frequently encounter nurse practitioners. I have found them on the whole to be well-trained, dedicated, popular with patients, and intelligent." But then you go on to explain your concerns, saying, quote, "I am, however, quite concerned about the implications that NPs completely replace physicians. It was never the intent when NP programs were begun to replace physicians, but to function as supervised physician extenders. There is a clear trend in place to not only regard NPs as fully qualified and able to replace physician generalists, but also specialists." And you talk about your experiences in the article referring patients to specialists only to have them seen by a nurse practitioner. And sometimes patients weren't even aware that they were seeing an NP and not a physician. Can you tell us more about that?
I just very clearly saw a difference in style, that they were clearly not physician specialists. A physician specialist, a really successful consultation is a collaborative effort. There is communication, and the communication goes both ways. And I've seen that. This isn't just a matter of signing off on a patient and sending to someone smarter than you, okay? It really does go both ways. I have on many occasions challenged what the specialist is telling me nicely, and we've gone back and forth and arrived at the correct management of the patient. My impression of what the nurse working in a specialist office was doing is really following a protocol. It's when we encounter the abdominal pain, this is what we do. And I wasn't really impressed that they had really considered the specific things that I had written in the consultation requests. My consultation requests tend to be very detailed and very specific. I didn't see that these were reviewed. I saw a lot of things that were redone, that had already been redone. And it really wasn't an effective consultation. Plus, there was a lack of transparency as to who the person was, as you and Maron have pointed out as a major problem.
So you talk about in your op-ed that the training of nurses is different from the training of physicians. And one of your quotes
yes,
was, the core of nursing training has traditionally been patient care, which means implementing a treatment plan. The main purpose of physician training is understanding illness and, of course, wellness and being able to diagnose and formulate a treatment plan. Both of these are equally important in achieving the goal of helping our patients get better, but they are still different. Can you elaborate on some of the differences in training between the professions?
yes. We go to medical school. We learn the diagnostic process, and we leave medical school thinking we know everything. And then we start residency, and then we find out, oh, we don't know everything. And you learn a whole lot during residency. Nursing is really based on the emphasis on nursing, and nursing is a very noble profession. It's a very difficult profession. They are saddled with the logistics of how these things happen. The doctor just has to write the orders, but how are 30 patients on the ward going to get all this treatment without mistakes? That's the nurse's job. The nurse figures that out. That's why management is, to a great degree, nurses are very represented within management of hospitals for that reason.
Maron, you've talked a lot in the book about the difference in training and mostly the ability to learn how to form a differential diagnosis. Do you want to share a little bit about that?
I think that's probably, in a nutshell, the biggest difference. And we talk about this a lot, that you'll send someone with a set of symptoms, whatever it is, sometimes even a diagnosis. And what I find fascinating is I don't see that same discussion, even in the note.
So, Steve, you wrote this very nicely worded op-ed, but it was just speaking the truth. Tell us what happened next.
About 2 or 3 days later, I was called on my day off by the secretary of the CEO, Dr. Rodolfo Jimenez, who said, Dr. Jimenez said, yeah, we'll use his name. Dr. Jimenez wants to see you. It's very important. She wouldn't tell me why. And so I was summoned. They asked me to wait in the boardroom where we have many staff meetings, and I just sat there on my own. Eventually, Jimenez walked in with the what do you call him now, human resources person, and with a big smile on his face, he said, unfortunately, I have to do something in my job that I regret doing. And he hands me a letter, and he says, here is your termination letter.
Wow.
Okay. I may not be recalling the words exactly because it was a little traumatic, but
You must have been in
that was the gist of it. And I said, yes. And I said, is this about the article I wrote? And he said, yes.
Wow.
You violated all of the principles of our organization. I don't know where he pulled that out of, and specifically the principle of mutual respect.
And you had worked there for 10 years with
Yep.
no disciplinary actions in an underserved clinic where children desperately need medical care. And yet this was the response to really probably the nicest criticism letter I've ever read.
And just to add, not to toot my own horn too much, but I had volunteered to work on Saturdays. So our patients didn't have to go to the ER. I volunteered to work evenings. And he had actually appeared once in a radio interview with me. It's the same Dr. Jimenez who ultimately fired me, who said what a great employee I was.
It's so interesting.
What a great provider.
Yes,
I was,
of course.
Which is a term we all like, I know. But.
Right.
What I think is so interesting is I want to read just a few more lines from your op-ed just to show the listeners how delicately and nicely you wrote this. You wrote, quote, "It was certainly not my intention in writing this to show any disrespect to nurse practitioners. There is no question that they are an important community resource for health education. They are a great asset in managing the complex health needs of patients with ongoing chronic illness who often have to navigate a complex system to address their needs. Some of them can teach some of us physicians a thing or two about bedside manner. This is truly an extension of the noble nursing profession." You just don't get nicer than that. And yet you were told that you have offended the value of respect.
Correct. That's what I was told. Yeah. I still haven't totally gotten over it. Now, happily, I'm continuously employed. For a while, I was doing locum gigs, which I enjoyed because I was appreciated. And it's important to be appreciated too.
It is. And what I also wonder about is obviously it seems to me that this was a political firing. And when I go on to the website of United Community Health Center, what I see is that there are twice as many non-physician practitioners as physicians that are employed, just like in many federally qualified health centers across the country. Part of that is because of federal funding that requires at least 50% of staff be non-physician practitioners for them to receive funding. But United actually has far more than they're even required to, I believe. If patients start demanding a doctor, not demanding, but asking about, should I be seeing a doctor, that could affect your entire staffing model.
Yes. And there are clinics that are taking that to even further extremes. When I was seeking employment in the Tucson area, there was one clinic, I won't name it, but they are hiring exclusively nurse practitioners. They won't even talk to you if you're a physician.
So patients have lost the opportunity, especially these underserved patients of lower socioeconomic means. They can't even see a doctor even if they want to.
Correct.
I think that's what Rebecca kept us going through writing the book as well. And our goal was that we wanted all patients to have the opportunity to choose who they want to take care of them. And I think information and we talk about informed choice so often and so much of what we do in medicine. And so I think this is a real important part of this. And I don't think necessarily people always understand or that it's transparent what the education is of your clinician.
So, Steve, what happened next after I guess you had to pack your things and leave immediately? It sounds like it was that kind of.
I was pretty much given the bum's rush out of the building. Yep. And I was given what you might call a tin parachute of 3 months' pay. And that was it. Okay?
Did you hear anything from community members afterwards?
I did. I got on Facebook. I got a lot of people, a lot of local response. What happened all of a sudden? Dr. Maron disappeared. He was so great. Our kids liked him. What happened? So it was nice in a way, with a little consoling to see that I had made an impact and people liked me and were missing me. And you know what? I'm still in touch with some of the mothers and they say, "Oh, Dr. Maron, we miss you."
I'm sure they do.
I'm sure they do.
So in your organization that you work in now, is it a better fit for you? Are you able to work in a more collaborative way with non-physician practitioners?
I'm going to be a little careful about talking about my present employment because I want to keep it.
Yes.
I can tell you I have had some interaction with nurse practitioners and it was very positive.
Great.
And actually, I was able to do like a virtual visit with a patient who I was very concerned about. And the nurse practitioners were at the urgent care. And I had arranged ahead of time, could you guys just give me a FaceTime during that visit so I could take a look at the patient and we could talk a little bit about the patient? And they were fine with it. No problem. And there was no egos were involved here.
And I think that's how many good nurse practitioners are. And there are so many. It's just, and the reason we have to talk about this is there are some that don't understand, especially those going through online programs. And I think pediatrics is the area that we worry about so much because I know I'm a family doctor. And so I have some pediatric training, but not as much as you guys do as pediatricians. And one of the challenges in family medicine residency is having the opportunity to see enough really sick children to get confident in your skills. And if that was a struggle for me going through many thousands of hours, I don't know how a nurse practitioner in pediatrics can be expected to gain that experience. I believe that the minimum number of hours is like 500 clinical hours. I know that's for family, but I think also it is for pediatric nurse practitioners. And I just don't know how you see enough sick kids to at least recognize those warning signs so that you know that you need to get help.
You don't get enough experience. You and Maron have pointed out that especially in dermatology, they really wing it. Basically, dermatology, you just look at something and whatever pops into your head at the moment, that's the diagnosis.
Well,
that's dermatology.
That is the challenge. Maron and I, in our book, we tell a story of a young girl named Maya Louise, who was, I think she was 10 years old. She developed sudden abdominal pain and vomiting, and her parents took her into a clinic. She saw a nurse practitioner who diagnosed her with a urinary tract infection, even though the child could barely walk down the hall. The child later died that same night of appendicitis. And at the inquest, the nurse practitioner said that she was confident in her diagnosis. And the problem is that it had never occurred to her to consider appendicitis. And in fact, she actually had access to a physician, but it didn't occur to her to ask for help because she didn't realize how serious the situation was. And I think that's why you have to see a lot of bad cases so that you realize what can go wrong and what bad even looks like.
Steve, whenever someone says they're confident about a diagnosis in pediatrics, I usually laugh because I'm rarely confident of my diagnosis. And I don't mean that I don't know my diagnosis, but I'm always afraid of what's lurking out there in the shadows that I didn't think of. And I was just wondering if you feel the same way after decades in pediatrics.
I do. I really know when I'm over my head, and I ask for help frequently. And I call up specialists frequently. I think, unfortunately, there is a lot of mediocre medicine out there. And as you and Rebecca have pointed out, there are a lot of good nurse practitioners. Nurse practitioners did not invent mediocre medicine. Physicians invented mediocre medicine.
Correct.
And which is that quick glance, whatever happens to pop into your head at the moment, just stack those patients, have 10 examining rooms, zip from one to the other. Some of us like to really think about the patients and really do the right thing.
And I think a lot of that comes from
medicine is about.
It comes from a broken system too that rewards high volume, quick care and quick fixes. And that's not the way that medicine should be practiced. I don't think most doctors start out wanting to be mediocre, but I think the burnout quickly ensues and you start to feel like a cog in the machine. And that is not conducive to practicing high quality medical care.
And my point I was trying to make it is that nurse practitioners are really, in their education, they're modeling that mediocre model.
Right.
It's all about what's the first thing that pops into your head. Okay, order those tests. It looks like maybe an X-ray. Maybe let's try steroids. Let's try antibiotics.
What you're trying to say is there's no scaffolding on which to build the picture. And I think that's why I think ICU nurse practitioners with ICU experience are really excellent because they have a scaffolding. They've seen system management. They've seen differentials. They've stood at the bedside and observed that kind of evaluation where doctors really don't always know the answers. And I think that's where medicine, you were talking about what medicine is about. Medicine is about the search for easing suffering, bringing comfort, helping patients, educating them. It's this search for that. And many of us do search on a daily basis. And I think maybe those who don't have nursing experience when they go to school, that's why I think I'm so concerned about these diploma mills. I think it does look like, hey, let's just pick something out of the top of my head. Whereas nurses with real bedside clinical experience, I think very much understand this larger picture that's necessary. I agree with you that there's definitely this element of that quick fix that or a shortcut actually is the way I look at it, a shortcut to a career.
Steve, I want to thank you so much for joining us, for your bravery in speaking out, and actually for really being probably the inspiration for me for getting started on this book. Because really, when I heard your story, I was truly devastated to think that someone that was as committed to patient care as you would be let go from a job just for speaking the truth. And that's when I realized that we have real serious problems and that the only way that it's going to change is if we get the word out to as many people as possible so that they demand change.
You and Maron are trailblazers. This is a topic that has been under the rug for too long, and it's going to be very visible in a very short time because you're bestsellers.
Thank you. Thank you for the plug. So we'll remind everyone to please get our book. It is called Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. It's available at barnesandnoble.com and also on Amazon Kindle. And if you're a physician and you'd like to learn more about spreading the word about physician-led care, we invite you to join us at physiciansforpatientprotection.org, where you can learn more about these issues. Thank you all so much, and we'll catch up with you on the next podcast.